Okay, so we have a patient on APRV, 65% FiO2. Previously, we had it at 25, and I just dropped the P high down to 23. And right here, we're using the auto release, so we're actually creating a P low that is not actually set, but we're determining the expiratory termination from the P high down to the P low based on percentage of peak expiratory flow, and that gives us a 9.7. So what we have here is a P high of 23 that drops to 9.7. So we have a drive pressure close to 14, so we have safe drive pressures. The P high could be in a way equivalent to the plateau as far as distending of the lungs. So we have this under 30, so that's also quite safe. What I did here was I tried to wean the P high from 25 to 23. I was at 25 P high around 483. At that time I had a slope of 0.3. So I went from around 180 to, I went from 480 with the slope at 0.3 and the P high at 25. And when I dropped it, it went around like 450. So we lost like 30 mLs about of volume, okay? So this is kind of what I looked like. I had a slope at 0.3. So let's look at the change in tidal volume. This usually drops the tidal volume because I'm lowering the slope, okay? So you see this is where I was. We went around 487 to 450, 30 to 40 mLs less of tidal volume with the release phase. We have a mean pressure of 19, okay? Now, if you start to increase the slope, very often you're going to have an increase in your minute ventilation. So what's cool is I was able to drop it from 25 to 23, and by readjusting the slope, I'm also able to have the same tidal volume that I was getting with 2 centimeters of water less. When you increase the slope, just watch out because it doesn't come up as quickly, and sometimes you'll have a slight decrease in your mean pressure. So you see, 0.6, I went up to 470, 480. So I was able to drop it by 2 and increase the slope and achieve the same tidal volume with less pressure. So now the issue is, great, we were able to drop the P high, less pressure, but are we de-recruiting with that P high being decreased? So this was pretty much the baseline look initially, and you see that there's a pretty good even distribution of ventilation all throughout the lung. 26% on the ventral, 40 mid-ventral, 24% mid-dorsal, and 9 to 10% on the dorsal regions. 8 to 15 is normal up here, and 35 to 40. So overall, a pretty good distribution of ventilation overall. But have we started to de-recruit with that drop in P high by 2? Okay, so this is the diagnostic panel for end inspiratory trend. Here we see the impedance values, and impedance curves are equal to volume curves. So as you see, when we dropped here from our P high of 26 down, and you see that staircase go to 24. I want to know, if I drop it, am I going to start seeing these impedance curves going down, which is a sign of de-recruitment? And look what's happening here. So what we're actually seeing is I dropped it to 24, and the impedance curves are going in the trajectory upwards. Underneath here, you could think of it as your functional residual capacity. impeding a trajectory going upwards after a change will represent an increase in FRC. Okay, so we're actually dropping and probably the lungs becoming more compliant, and we're able to actually have better recruitment. Let's look at this. We're comparing the reference of 26 to 24, and that's from 11 o'clock to 11:20. So we've trended about 20 minutes so far. Let's bring it back here. This here will appear, it's always comparing your reference to your control, and your control you can move all along the time axis here. Okay, and all of the information is given here, so you're not losing track of where you are. So the PulmoVista is in communication with the ventilator over here. Okay. What else can we draw from here? So we know that there's an increase in end expiratory volume with a decrease in the P high, with an adjustment of the slope to maintain the 480. So let's look at the blue as we go. So we see as we dropped it, okay, we're actually getting an increase in distribution of ventilation. So think of it kind of like this way. You know, when you're in ACPC, and let's say you are at 28 of peak inspiratory pressure on ACPC, and then you drop it to 26, and the tidal volumes remain the same. You're like, oh great, I'm getting the same tidal volume with less pressure. You drop it again, let's say to 24, and the volume actually increases now with that pressure. So you know that you're in a more compliant area, right? You know that you're probably slightly too high and you're in the non-compliant region. This is in a way a representation of that. All right, and we just bring it to the end. Okay, so I know right away with the color that from 26 to 24, I did not lose any of the inflation distribution here. I can tell right away that I'm actually improving my functional residual capacity, that I'm actually getting more and more lung volume at the end of expiration. But it doesn't tell me how much milliliters is happening here. So for that, you're going to have to go to end expiratory lung impedance, or end expiratory lung volume. Remember, volume and impedance, you can interchange that. I'm just going to bring it a little longer, just refreshing the page. All right, so now we're in the end expiratory lung impedance. Again, you're following here, right here. This is my 26. And now I'm going to bring this guy here from the 26. I'm going to bring it across now. So that's roughly 25 minutes. So let's look after 25 minutes what's happening. Again, you see that you're not losing any end expiratory lung volume. In fact, you're improving it. And here you see that these remain pretty straight. I'm actually recruiting more end expiratory lung volume in the mid-dorsal region, and the dorsal region is staying pretty constant, indicating I'm not losing any of the recruitment in the dorsal region, which is the important gravity-dependent region. Okay, so here we have the impedance values, and remember, just like the curves that equal volume, the numerical values also are equivalent to volume. So if you have positive impedance values, that means that there is more end expiratory volume in those regions. Over here, you see that there is negative, so there's less volume going to that area. And you can actually see the negative values here represented over here in orange. So what's happening here? We decreased the P high from 26 to 24, and we have less volume in the ventral areas, which is probably not an issue. It was probably, you know, a little bit lower the P high, and now we have less ventral filling, which is, you know, we're more concerned over here. And what it's also indicating is that there's less here, but there's more lower down. Right, less here, ventral, mid-ventral, negative impedance values, and now this here is lost because it's been redistributed to the dorsal and mid-dorsal region, which is excellent. That's exactly what we want. And finally, a third way of verifying and guiding us using a APRV here is, again, up here, we see that 26, it drops over here to 24. Again, it's also showing the impedance values, and you see underneath this dark area that's increasing is representative of your functional residual capacity increasing. So when you look from here to over here, we could also do this customized analysis and look at, is the compliance from here to here better, worse, no change? So we just press customized analysis. It's about to load. Okay, so here's my reference. Here's where we are. It's probably 35 minutes after. And by dropping your P high, you're not seeing any orange, so you're not seeing any loss of compliance in any of the regions. And you can see that there's a slight blue here, which is a 7% increase between 26 and 24 over here, which makes sense. If you're too high and you bring down the volume, you're in a more compliant area. The compliance improved on the ventral area because maybe there's a little bit of over distension. So we have three ways that we verified the adjustment on APRV. Using end inspiratory trends, using end expiratory tidal volumes, using regional compliance percentages. So this is the proper way how to individualize mechanical ventilation. One thing also is the blue here starts appearing when there's more than 10% of ventilation being distributed to that region, okay? As more percentages increase, you'll see this white saturation. So this big blip here that's kind of in the mid-ventral to ventral regions, it's saying, look, there's aeration, there's good aeration at the bases, 10%'s going, that's all normal. But this here is a very concentrated amount of tidal volume going to this region. So when you see this kind of stuff here, you know that it's worth going down on your pressures, either your P high or your pressure control, or even tidal volume if you're in ACVC. And what you want to do is, it's okay if I reduce the power of the vent and I'm losing the intensity here, because it might be indicative that there's, you know, a little bit over distension. You want this white distribution that's considered the maximum amount of ventilation to be as evenly distributed as possible. So, I mean, you do have some white saturation. I'm not saying it's all blipped over here and that's where all the tidal volume's going, but it's a quick also way, just an immediate information to say, oh, a lot in the tidal volume, a lot of it is going to the ventral and mid-ventral regions. Hey, let's bring down the pressure or the power of the vent, and let's see if I'm losing here or if I'm losing here. Probably if I start, you know, losing the intensity of the maximum ventilation in the upper regions without losing, that's a really quick indicator if you're in a hurry to know that, yeah, you know what, it's giving me some information that maybe it's a good idea to try and wean down these pressures. All right, so this is the next day. Since the patient was like hovering on 75% oxygen, seemed like there was a normal distribution of ventilation. I'll pop up the other image where you see that it's well distributed, but the white intensity, it tends to be around the ventral areas a little bit more. So we're flipping the patient, and we're hoping, since there was good ventral distribution initially, that when we put the patient in a prone position on their stomach, well, then there's might be a better ventilation of perfusion. We're still at 83% FiO2, so we're actually higher for now, but we're going to try and, you know, adjust the pressures, see if we can recruit this area a little bit more, which would be the dorsal area, which right now is this. So we're going to hopefully get more distribution here, do some higher pressures, recruitment maneuvers, and we'll go from there. So at the moment, the patient has 5.4 cc's per kilogram. P high is 24. I'm aware I have no gloves. I'll disinfect my hands after. Of 8. I think that's a little bit too low for a P high, and that creates a high drive pressure also of 16. We want to stay under 15 ideally. All right, so let's get to work. So we're going to increase it by 25, and what we're going to look for is here, these are the impedance curves. So we're going to look for an upward trend. If I went from 24 to 25 and I start seeing a trajectory this way in the impedance curves, it means I'm recruiting somewhere. And then I can go to the end expiratory lung impedance values. And these will also give the global one that we saw in the other one, trend. This one's more specific because over here, it kind of gives a global trend. You don't know, you know there's recruitment happening, but you don't know, is it dorsal, ventral, not sure where things are going. But with this diagnostic screen, you also have the global, and then you can be more precise, ventral, mid-dorsal, and dorsal, where's the recruiting happening. So far, it kind of looks encouraging. The ventral region's going down, and the mid-ventral is going up, the mid-dorsal is going up, and the dorsal is going up. That's the most important, because we were seeing here that it's missing some here. So it might take some time to start appearing the blue. And if you want to see, like, okay, these are impedance values. Impedance is equal, like I said, to volume. So we're definitely recruiting more lung. It'll take some time. If you want to know what 2.31 is, like what's that value? Multiply that by the reference tidal volume. So 374, right? Let's say just times 2 is 600, let's say 600 and something, almost 700. So we've actually increased the functional residual capacity by 600 mLs. So that's a good thing. All right, so let's just leave it there while it's recruiting on 25. And we'll just keep on going up that way. Then after, we can go to the diagnostics, where we're going to look at regional compliance values. I can add this just quick, like this, where we are now, and we can customize. So from going from 24 to 25, we have a slight improvement of 7%, so the lung's a little bit more compliant. So we'll do that in about an hour. Okay. All right. So we went from 24 to 25. We're only looking at the moment to about 12 minutes in. All right. So don't forget, now he's on his stomach. So this is the ventral area. Makes sense. Now that there's more weight on the ventral area, it's compressing it somewhat. So we're losing the pressure that is on the ventral area, which is completely fine, because yesterday when we did it, we saw that the majority of ventilation was on the ventral area, which that's not what we want. Also here, it's going up, going up, going up. So the most important is the dorsal region at the end of expiration going up consistently, and that's just with a one increase from 24 to 25. So I'm not in any hurry. I could have been, I could have just tried, like, no, forget about it. Let's start with the recruitment maneuver and then go down. There's no hurry right now. I'd rather be as gentle as possible. So we're just going to keep tracking where it's going. You can see that, things are switching around. We're losing air here. Okay, makes sense. The guy's on his stomach, so there's less distribution there. That's what this negative impedance value here in region of interest 1 ventral is represented here. So, I mean, it's wonderful. You have the numerical values, which you can multiply with your reference tidal volume to actually put these into milliliters. You have the impedance curves, the trends that show you visually very quickly if we're going up or down. And then you have the color code, which blue means a gain in impedance, gain, and orange means loss. Okay, I love this machine. So I'm hoping to start seeing higher percentages coming up here overall. One of the good things, though, is that it's well distributed, that maximum ventilation. When you compare it to the other one, it was kind of like up here was maximum, there's blue coming down here, but it was white concentration. This at least seems to cut right in the middle. There is an even distribution of that maximum ventilation. There's not a blotch anywhere. It seems to be centered in the ventral and mid dorsal regions. Hopefully we're going to start seeing this area maybe open up after some time, and then that'll probably also shift the white into a bigger loop. That's my hope. I'm hoping the other one just gives compliance win in blue and compliance loss in orange, and it'll pop up regionally. This is kind of another angle of looking at it. The compliance loss, high part, compliance loss, low part. So here it'll turn orange if you're losing compliance in an area, which is possible over distension. White areas is atelectasis. So this was the jump from 24 to 25, and we see that there's a slight drop in this area that was causing an issue, and then it disappears the minute we go to 25. Zero orange here, no loss. So we're doing good. No loss in compliance everywhere, a little bit less de-recruitment, and recovering our functional residual capacity over time. Okay, so here's another regional compliance diagnostic. So this was 24, this was 25, this was 25 after a little more time, and this is 25 still. So if you look here, 24, and when we jumped to 25, we had a 6% improvement in compliance, then 11, now it's staying at 11. So we're going to go to 26, and we're going to see if that is better. And we're just going to keep on increasing the P high as long as the compliance improves and we don't see any increases or orange areas on the lung. It's hard to see, but you get in quite close, hopefully. We'll try and hide the light. You see? Shucks. There are 2, 3 little blue areas right there. So that would be the areas that you're increasing compliance, like on the edges, the periphery of the lung. But still not able to completely open that. It's not horrible. I mean, it's just a little patch here missing. But the good thing is that we're 2% higher in the dorsal distribution of ventilation. I see 8 sometimes happen. So we have 3% more of the 423 being distributed probably around here. Doesn't mean that there's no distribution at all here. It's just that when it's under 10%, it doesn't necessarily show. Once you have 10%, it shows in blue. And as you have more and more percentage, it'll show up in white. We're increasing the P high incrementally, taking our time, using the end expiratory lung volumes, see if we're recruiting, trying to send the gas more to the dorsal area and remove a little bit from the ventral area. That's probably occurring just because of the prone position. There's more pressure on the chest. We got the weight now bearing down on the chest. So that's why we're seeing that orange on the ventral area, and we're seeing blue starting there, okay? And then after, don't forget, then we do the diagnostic, the custom analysis, where we're looking for regional distribution, changes in compliance, changes in regional compliance. So then after, you just, check all the different levels, and as long as you start seeing increases in compliance in those regions, you're more confident to increase it. You're really not guessing at all. We've weaned down to 70%, which is great because we're at 75 and was kind of stuck there at 75. Patients setting 93, 94%. So already within probably an hour of being prone, we're seeing 5% less than when the patient was on his back. Sometimes with APRV, especially changing position, or when you start APRV, it can take anywhere from 8 to 12 hours for recruitment to occur. It's not a mode where you put it on quickly and say like, no, the SAT didn't improve. You need time. You know, and it all depends also how brave you are with starting. You know, if you start with a T high of 5, you know, you might have to accept some permissive hypercapnia. But if you start with 2, let's say because they're too acidotic and you want to bulk ventilate, well, it's going to take longer to recruit. You know, you'll have to sneak up that T high with the blood gases. So it depends how aggressive you want it. I just wanted to show you how the PulmoVista 500 can be used to individualize ventilation using APRV. More specifically, time-controlled adaptive ventilation is the way that we use APRV here. And there's a lot of criticism sometimes. Well, there's no studies, and you know, it could be dangerous, and you get challenged with it, and that's fair enough. But if my plateau, if my P high is, what's the difference between a plateau of 25 and a P high of 25? And if the difference between the P high of 25 and the P low is safe within, you know, underneath 15, well, that's like a drive pressure. So yeah, you know, you still respect the drive pressures. You still respect the P high like a plateau. You still aim to have 6 to 8 cc's per kilogram. I know clinicians that use APRV a lot in the ICUs, and now again, there's no studies for that. Okay, so you know, I'm putting myself out there to be criticized, but sometimes we tend to tolerate 10 cc's per kilogram. That's because when you're using ACPC or ACVC, you have a inspiratory time, you know, of 0.6 seconds, 0.9 seconds, and we have the time constants, you know, right, in the lung. Alveoli have different time constants. So, you know, if you're going to recruit those alveoli with longer time constants when you have 5 seconds you know, inspiratory time, like a T high of 5 seconds, instead of a T inspiratory time of 0.8 seconds. So when you've recruited more alveoli and you have that drop to the P low level, sometimes the volumes can you know, be higher, but that's not necessarily larger volumes being driven into the lung. It's a recruitment that's happened with pressure over time and then a release. That's at least the way I justify it in my head. But if you look over here, we're still within very safe levels, right? I'm just going to switch the phone around. All right, sorry. Yeah, so, you know, we're using APRV, okay? The plateau, or the P high, is 26. That's under a plateau of 30. That is safe. We have 6.2 cc's per kilogram. That is safe. We have an expiratory pause here. Let's see. So this is 9. So 19, 20, 22, 23, 24, 25, 26. So now we have 17 of a drive pressure. Okay, it's a little bit high, but that's because I've been incrementally increasing this. When we were at 23, the drive pressure all shift was around 14. But as recruitment happens, if recruitment happens, then we'll probably be able to drop that drive pressure too. So that's the way, using APRV, more specifically time-controlled adaptive ventilation, and then guiding every single step with the PulmoVista, with the end inspiratory trends, with the end expiratory lung impedance, doing a diagnostic custom analysis, looking at regional compliance areas. This guy here. Even though there's no studies, we're really not going blind. In fact, I'm staying hours at the bedside, slowly adjusting 1 P high at a time, waiting for time, getting measurements. I'm not doing this blind. And I feel that using APRV this way, study or not, I'm still getting the benefits of the previous studies of low tidal volumes, of optimal PEEP, of drive pressures and plateaus below 30. So I guarantee you I have a bias on APRV, but I've been using it for 2 years. We have not had barrel trauma. We have not had lung trauma. When we start out here, okay, with a T high of 2, just give it a few breaths. Okay. So it's kind of, if you look at it, it looks like a ACPC profile, the decelerating flow waveform. The great thing about it though is that there's no trigger. This is a whole CPAP level. So I find when we do ACPC, but we use PCAPRV in a TCAV method, start with ACPC, create the mandatory releases, which are the breath, they're acidotic, bulk ventilate. Let's say here, all right, let's say here, I have a good blood gas. Okay, great. Why don't I stretch it a little bit more? So now it's ACPC looking, but we're starting to have a long stretch. I do another blood gas. Awesome. It's good. Stretch it down. And before you know it, you have a stretched out patient. So you start with ACPC, you start with PC profile, and as you look at the diffusion capacity of the patient, then you stretch it out and optimize it. Because you're stretching it out, this area here, while it is inflated on the P high, if the patient has the capacity to diffuse, he's going to be diffusing. So those releases are going to be a lot more potent with CO2. Therefore, you often can have a much lower minute ventilation, or a much lower rate, and that makes the chest move less, and that's a good thing. So that's kind of my crazy bias on APRV.